So we're a little ahead of schedule, but we're going to keep on rolling. And we're going to next introduce Dr. Amber Schmidtke. Dr. Schmidtke holds a PhD in medical microbiology and immunology from Creighton University School of Medicine. She worked in public health for 4.5 years at the Centers for Disease Control and Prevention before transitioning to work in higher education. She was previously an assistant professor at Mercer University School of Medicine in 2019. So giving today's talk feels a bit like coming home. During the COVID-19 pandemic, Dr. Schmidtke became one of the most trusted voices in Georgia, authoring a popular newsletter and podcast, consulting government and private entities, and offering countless media interviews. She now serves as an associate professor of microbiology and assistant dean of student success at Kansas City University College of Medicine. She is a mother to 2 teenage boys, Lord help you, and has been a military spouse for 22 years. Welcome, Dr. Schmidtke.
Okay. Well, good morning, everybody. I'll admit that I'm usually a bit of a walker when I present, so this will be interesting to be constrained to a podium, so give me some grace. But just show of hands, who has seen measles in the wild? Not a single person, neither have I. And so I'm here mostly as a medical educator, right? To make sure that you have the information that you need, that you can take home to your communities and be sort of that local authority on measles. What does it look like? What do we need to do when we see it? What is our decision tree? That sort of thing. So today you're going to see, it's certainly an overview of the disease, but I also want to pepper in a lot of practical, what do I do kind of stuff. So there's going to be a lot of resources that I sort of draw your attention to, because much like we saw in the COVID pandemic, sometimes it's hard to figure out where is the good information and how do I stay apprised of local conditions, or, usually the best data are recent and local, right? And so sometimes, if they're reporting this many cases in Georgia, but you don't know where they are, that's not real helpful, right? So we're going to talk about where can you go for information so that you're really well informed. So first, I just want to thank the Georgia Rural Health Innovation Center for funding my travel to come to this today, but I have no other, conflicts of interest to declare to you. My hope is that by the end of this, you can name at least 3 key signs and symptoms of measles. I want you to be able to tell what kind of diagnostic tests are useful for confirming disease. You do not wait to hear back from the lab before you report it to public health. I want to be very clear on that. And then also we'll talk a little bit about the MMR vaccine, so that you are better equipped for those conversations with parents. So we'll get started. Measles is, like we all know, none of us have seen this in the wild, but it's a disease that's existed in human history for as long as we've been keeping records. It's a single-stranded RNA enveloped virus that's part of the Paramyxoviridae family. It is one of the most contagious pathogens we have. I remember during COVID, when we were waiting to find out what is the R naught value, or the how many people are going to be sick based on an initial person's illness. And when it came back that it was in this zone, sorry, I don't know if I can, when we found out it was in this zone, I remember it giving a huge sigh of relief, because I was like, at least it doesn't move like measles moves. COVID could have been so much worse if it did. So knowing the disruption that COVID caused for us, pay attention to what's going on with measles. It's this one down here. So you can see that it's going to spread so much more than what we saw with COVID. So it is considered an endemic disease among the human population, but it has been eradicated in the United States up until this year. This is why we can't have nice things. So it is exclusive to humans. There is no animal reservoir for this, and there's no asymptomatic carrier state. Now, during the incubation period, people will be asymptomatic, but we don't have people who are sick without our knowledge. They almost always, or really always, are going to have some of these signs and symptoms. So like I mentioned, this is an old disease. It's been with us for a very long time. And so I want to first talk about what did this look like during the pre-vaccine era. It became a notifiable disease in the United States in 1912. And during that time period, we were having an estimated 6,000 measles-related deaths per year, and an estimated 3 million cases that were reported. But as you know, if you've ever worked in public health, what we know is usually the tip of the iceberg. We suspect there were a lot more cases beyond that. And plus, record keeping was a little tricky back then. It was before the dawn of the internet and all those other things. During that time, annually, we saw about 48,000 hospitalizations and about 1,000 cases of one of the complications, encephalitis, per year. Then we had the vaccine. And I always love this graph because it really is kind of like one of the success stories of public health. It's no longer a success story, but it was. And so we used to have a lot of disease, right? And in 1963, the vaccine was introduced, and you can see what happened to disease incidence after that time. It plummeted down to virtually nothing. And so the first version of the MMR vaccine featured a killed virus. And you can see that the cases dropped for sure, but we still had these bumps and spikes. And so we then released an updated version in 1968 that was a live attenuated virus that had better efficacy. So that's why that has happened. It was declared eliminated in the United States in 2000. And as you know, it was only imported cases up until just a couple years ago. But this remains a really significant disease internationally. So globally, it's estimated that we have over 107,000 cases, or rather deaths, per year. And that's as of 2023 from the WHO. So, yeah. And then in 1989, we went ahead and recommended the second dose. I remember this one because I was in junior high when it happened. We all had to line up for it. And so, so we recommended that second dose, and that really took us up from like a 93% efficacy to a 97% efficacy. And so that's been sort of the history of the vaccination policy here in the United States. I'm a public health microbiologist, so the thing I care most about is how does this thing move and how do we test for it and that sort of thing. As I mentioned, this is the most contagious pathogen we have. And what's really tricky is that people are transmitting the disease before we know that they're sick, which is often the case with respiratory illnesses. So from about 4 days prior to about 4 days after the appearance of the rash that occurs, they're in their contagious zone. And if a person is sick, 90% of the people who are around them who are vulnerable or don't have pre-existing immunity will get sick. So it's a very high attack rate. And part of the reason why it is so contagious is because of the way that it moves. So you remember from COVID that respiratory droplet transmission was the name of the game. And usually they were in the higher weight respiratory droplets. When you cough or sneeze, they're really heavy pieces of mucus that get expelled. Because measles is a lightweight virus, it tends to exist in the lighter weight particles that come out when you cough or sneeze, and it stays aloft in the air for up to 2 hours after a person leaves that space. And so for that reason, we do not necessarily have to have direct contact transmission. We can have a situation where somebody comes into an elevator, and that elevator is now, a sort of a hotbed of disease for the next 2 hours, and we may not know it. So that's a problem, obviously. Less commonly, we can see fomite-based transmission, but it's not quite as common. And so really my key advice to you, and this is the same thing I teach to nurses and I teach to physicians, is assume everything is contaminated. You should be doing that anyway, but especially in the context of measles. Okay, so I wanted to give us kind of a timeline of events. So that you know what to expect. Under best case scenario, this disease is going to progress in 27 days. In the more, lengthy cases, it could be up to 46 days. So there's 4 key stages. The incubation period can last anywhere from 6 to 21 days, and it's going to feature 2 viremias. And during this time, the virus is going to enter through the respiratory mucosa or the conjunctiva, and it will invade respiratory epithelial cells, alveolar macrophages, and then also dendritic cells in the lung. And that's part of what transmits it, obviously, to the lymph nodes, and then we have that viremic spread. to the lungs and the lymph nodes, like I mentioned. During this time, they're asymptomatic, right? There's nothing really, there's no hallmarks to look at. Then we progress into the prodrome, which looks like flu. And that's the problem in public health. When everything looks like flu, you don't really know what you're doing. And so this is going to feature fever, usually a very high fever, anorexia, conjunctivitis, coryza, and cough. From there, it's going to spread to the intestines and brain. And one of the pathognomonic things that you can see are these spots inside the mouth. These are called Koplik spots. And I hope you can see this on the picture. But basically, it looks like grains of salt on a red background, is the best way to describe it. Not all measles cases will have this, but if you do have it, this is the only thing we know of that causes this. So if you see it, think measles. From there, this is usually a 2 to 4 day progression, which means that they are contagious through this period. And the real kind of one of the big hallmark points is when that exanthem appears. So the rash is going to start 2 to 4 days after fever onset, and it's going to be a red maculopapular rash that can become confluent. It will blanch on contact. So, for example, it'll be a red rash, and when you touch it, it turns white and then fades back to that red color. What's really helps us to distinguish measles from other viral rashes is the path in which it spreads. So it's going to be a cephalocaudal tract. So it'll start on the face, usually by the hairline, and then move down to the trunk and out to the extremities. And again, they're contagious for the first 4 days. After that, we have the recovery period, which can last a week or two. During this time, they will usually have a cough that lingers through this whole thing. If fever is still present during this time, that's usually a sign that you have a secondary infection going on, and it's time to do some workup on that. Typically, when people have measles, they will have immunity for life, but that comes with certain costs, and we'll get to that in just a moment. But they will have something kind of like an immune amnesia that lasts for about 6 to 8 weeks after infection, because the virus does go after memory B and T cells, and so they may have increased likelihood of otitis media, pneumonia, or things that they've previously been vaccinated against. Sorry. Because the exanthem is such a hallmark feature of this, I wanted to spend a little extra time on this. So again, it's not an itchy rash, but it's flat and maculopapular. And initially it'll be red and then fade to brown as the disease progresses. And when it turns brown, it's no longer blanching. What can help differentiate this from something like hand, foot, and mouth disease is that it does not typically involve the palms of the hands or the soles of the feet. And you can see some desquamation, in some of the more severely impacted areas. The degree to which this rash is confluent or how far it spreads across the body correlates with the severity of illness. So if a child or even an adult has kind of, not a ton of spots, that means it's a milder case. If it's all over their body, that's going to correlate with more severe disease. Again, like I mentioned earlier, this disease features a very high fever, sometimes in excess of 104 degrees, and it usually peaks 2 to 3 days after that rash begins. Again, if you see fever beyond that point, please be on the lookout for secondary infections. So like I mentioned, when everything tastes like chicken, when everything looks like flu, we kind of have to think about what else could this be. And there's different things that it could be during that prodrome period, as well as during that sort of acute phase exanthem period. So in the prodrome, and actually throughout this whole thing, you could be looking at something like dengue fever. During the prodrome, you're going to be looking at typical common respiratory infections that are features of childhood. And then I want to point out there's this thing, another spot that can sometimes be confused, and dentists especially will be the ones to see, it's showing up on mine, but not, there we go. So up on the upper left, you have these Fordyce spots, which are also on the buccal mucosa, but they are not white. They are usually sort of the same skin tone as what you see in the background, which is different than what you see on the Koplik spots, where the mucosa is inflamed and you see those white spots. During the exanthem phase, and I've got a chart that we can look at in just a moment together, you're going to be thinking about all those viral pediatric rashes that could occur. You could also be including things like group A strep in your workup, but also drug eruption. What have they been taking recently? Rocky Mountain spotted fever and infectious mononucleosis. So I made this, but it's based on, I scoured up to date. I'll be completely honest, because I was trying to figure out, like, what can I give you that will help you to distinguish one thing from another? And so measles is our friend here, not a friend, but our thing that's here on the top. And all of these things have rashes, different characteristics. Remember, this one is not going to be vesicular in nature. So if you see vesicles, start thinking about chickenpox and things like that. Again, the degree and the path of the rash spread is really important. And so these are going to be questions you want to ask the parents. Where did this rash begin? How has it changed over time? That sort of thing. And then also the association or not of a fever. And so with measles, yes, and it's high, but that's the same thing for roseola. And so then we're looking at other features that can help us to distinguish some of these viral rashes from others. There can be clinical variants. So these clinical variants I'm about to talk about are not considered contagious because they had some pre-existing immunity. They're not likely to spread it to others. I hope that all of us have been vaccinated for measles during our lifetime. So what this could look like for you is something like modified measles if you were to catch it, or if I were, hopefully never. But it could be something where, somebody didn't seroconvert, or maybe it was a baby that had transplacental transfer, or a prior history of measles. And so with this, you're going to see a milder presentation. You're going to see a longer incubation period. So this can be a little bit confusing, but again, they're not contagious, but it might be something to keep an eye out for when if you ever have a child that's got measles. Pay attention to what's going on in the family too, because you could see something like this. We can see, although it's much more rare, atypical measles, and this is primarily affecting people that were in that in-between period where we had the killed virus and then we switched to the live virus. So there's like a 5-year span of time where if they were vaccinated during this period, they will see this thing. The key thing that's different here is how the rash spreads. Rather than being cephalocaudal, it's going to go from the extremities. It's basically the reverse order. It's going to go from the upper extremities and spares the chest and neck, but spreads upward. It can be a varied presentation across patients. Sometimes the rash will be itchy. Sometimes it'll be vesicular. And so this is really kind of a weird one. You're more likely to see it if they are a family member or caregiver of somebody that has a current measles case. So again, not transmitting, which is a blessing. So complications, unfortunately, are common. Remember, I said most people are going to survive this thing. But the reality is, and they have immunity for life, but the reality is it doesn't come without cost. And so 30% of people who have measles are going to develop one or more complications. Some of the more common things include immunosuppression because the virus goes after memory B and T cells that can result in secondary infections that include things like bacteremia, pneumonia, which is very common, and pneumonia is actually the #1 cause of death associated with measles. Gastroenteritis and otitis media are also common. And so that immunosuppression or immune amnesia can contribute to increased mortality that lasts up to 3 years after their infection. So this is a long-term thing that we need to be really following up with these kiddos primarily, but adults as well if they have it. So again, the most severe complication is that pneumonia, and this happens in about 1 in 20 children. And we have neurologic impacts as well, which can be very scary. A lot of our information, because we don't see measles in the United States up until recently, comes from overseas. And so in Namibia, there have been some reports on what happens with pregnant women when they are infected with measles. They have a higher risk for things like premature labor and low birth weight. And in fact, they can have more severe complications, including, diarrhea can be severe, but 60% of cases had diarrhea. 40% had pneumonia, 5% had encephalitis of those who had complications. 60% of those pregnant moms had one or more adverse maternal, fetal, or neonatal outcome, and 12% of the pregnant women who were infected unfortunately passed away. So in our developing countries, this remains a significant disease burden, and we certainly don't want to see that here in this country. So here's where I start to give you a lot of resources. So this is an infographic that comes from the Georgia Department of Public Health. You can print this, post it in your clinic if you wish to. The diagnosis is something that we mostly base on recent travel history, including international travel, but also certain parts of the United States where we know that outbreaks are active at this time. But it's also based on the symptoms. If you see those Koplik spots, if you see the rash that starts at the hairline and spreads out and down, those are good indications that you've got measles. And so we want you to report that immediately, whether you're a school nurse, a physician, doesn't matter who you are. If you think that you've got a measles case, report that to public health immediately. Do not wait for labs to come back. And they can give you guidance too, in terms of, make sure that we're isolating this kiddo or, that kind of stuff too. So the tests or the specimens you're going to want to collect include a throat swab or NP swab. You can use urine for RT-PCR. We can also collect serum to test for IgM serology. And the ideal window for this is within 3 days of that rash onset, the exanthem, but no later than 10 days, because past that time, we're not likely to, it can be very confusing results. So the Georgia Department of Health is basically, they start from a posture of, because we have a very low disease incidence in Georgia, our primary sort of decision matrix criteria is recent travel and exposure risk, right? And so then they go into symptomology and that sort of thing. The CDC offers an alternative where, and this is where they start more from the symptomology and then go to exposure risk. And this may be important, especially if you have a situation where, we don't have measles in Georgia very much anyway, but I think this person, I really truly think I see measles here. This would be a decision tree to start with. And there's some notes attached to this. I think you guys are getting these slides at the end, so I wanted to provide complete information, but this comes from the CDC. Unfortunately, I know you came here wanting to know how to treat your patients when they have this. The unfortunate reality is we do not have a specific antiviral for measles. Why not? Because we don't have measles in this country usually. There is no good return on investment for our pharmaceutical industries to create an antiviral for measles when we have an extremely safe and effective vaccine. And so I would not count on a specific antiviral coming online anytime soon. There have been some anecdotal reports that ribavirin can be helpful. It reminds me a lot of what we saw in the early days of the COVID pandemic, where providers were really kind of throwing spaghetti at the wall to see what would stick in terms of treating patients. So take this with an enormous grain of salt, right? That we do not have any clinical trials to verify the efficacy of using ribavirin, but if you are out of options, that is something that you could consider. Really, the recommendation is treat what you see. If you have pneumonia, then treat for that. If you see pain or fever, treat for those things. But we do not have something specific for measles. There has been some misinformation going around saying that vitamin A can be sort of the silver bullet against measles. Unfortunately, there's no real evidence to back that up. The thought process behind this, though, is that during a measles infection, a person's vitamin A stores will be depleted. And so the thought is if we can restore some of that vitamin A, they will be better able to fight the infection as they're infected or as they're progressing through their case. But it is very, very common to see secondary infections. And so it might be a good idea to do antibiotics as prophylaxis during this time, especially if they're admitted. So again, treat what you see and hopefully have a lot of good conversations about vaccinations. Because the old adage is an ounce of prevention is worth a pound of cure. Money isn't everything, right? But it costs $1 to vaccinate somebody for this. When we have an outbreak, it costs upwards of $150,000 per case for us to control this thing. So we are, again, money is not everything, especially with kiddos. But as far as the societal burden and impact, it is significant because of how contagious it is. The MMR vaccine is a very, very effective virus or vaccine. It features a live attenuated virus, so that means that the virus can't actually make you sick, or not in fulminant cases, but we like those live attenuated vaccines when we can do them because they really stimulate a strong immune response. So with a single dose, we have 93% efficacy. We recommended that second dose in 1989, which brought us up to 97% efficacy. And so something that's really interesting is we're kind of seeing this play out with the current cases. 96% of the cases that have been identified in the U.S. this year are among those who are not vaccinated or not fully up to date on vaccinations. It features, as you're probably aware, a childhood series where they receive their first dose after their first birthday, and dose number 2 is right around the time that they enter kindergarten. If you have children that are going to be traveling internationally, if you have infants between ages 6 and 11 months of age, you can go ahead and vaccinate them early and then keep up with the vaccine schedule after their first birthday. We've been recommending that for international travel, but now there are states that are recommending that for local populations if they're in an outbreak affected setting. So we can consider adult boosters if needed. If you run a titer and you find that they don't have sufficient immunity to measles, you could offer that. You could do it before entering college. That's something we see real commonly. And again, if traveling internationally. Like I said, most folks survive this. Again, not without cost. We can have some real serious complications, both in the near term as well as the long term. And so, like I said, you have that immune amnesia that can last for about 3 years. We can also see in developing countries that this is a significant cause of blindness because of that vitamin A depletion that happens. One of the probably scariest complications is a persistent measles infection that never totally clears called subacute sclerosing panencephalitis. This happens when children are infected before they're 2 years old, and then this condition emerges 7 to 10 years later. So again, they never totally clear the virus, but it kind of comes back to life after 7 to 10 years. And it starts real subtle. And remember, these are going to be preteens, 12, 13-year-olds. So they're going to have mood changes, and what 12-year-old doesn't? That's my question, mother of teenage boys. And so, it starts real subtle, but then it progresses to something far more serious, including seizures, coma, and death. Unfortunately, there is nothing we can do for this. There is no cure. So the mortality rate for this is 95%. And this is reason enough for me to be fully vaccinated. But not everybody is aware of this, I think. I also wanted to equip you and really cause you to think ahead about what are you going to do if measles arrives in your town. I think it's better to prepare for the when, not the if, because a lot of these things are one car ride or one airplane ride away from us, especially here in the United States right now. The population that you are serving is going to be very diverse, as you know. It's going to include unvaccinated newborns and infants. It's going to include pregnant mothers. And so we need to be thinking about all of these folks who might be immunocompromised or not have that pre-existing immunity, and how can we protect them if we have a case that we want to treat in our clinics. So the recommendation, and this isn't just me telling you this, the American Academy of Pediatrics as well as the CDC recommends this, triage by phone as much as possible. When they call to schedule their appointment and they tell you that they've got a rash, get somebody on the line that's got some clinical training that can start to run through sort of a brief differential diagnosis with them. Do they need to be seen in clinic? Is it possible for you to do a house call? Is it possible for you to see them in their car out in the parking lot? Those would be ways to avoid bringing that disease into your clinic. But otherwise, if you're going to bring them into your clinic, give them instructions on which door to enter into, take them to the nearest exam room, and just know that you are not going to be using that exam room for 2 hours after they depart. It should be sealed off to everybody. There's a typo here. It says masks for anyone under 2 years of age. It should be masks for anyone older than 2 years old. So forgive me for that error. And so, like I said, leave that room vacant for 2 hours. But once that 2 hours is over, just standard cleaning and procedures will be sufficient to make that room safe for use again. As healthcare workers, I am hoping you've already done this because of COVID, but make sure everybody in your clinic has been fit tested for an N95. And make sure you have some on hand. This is one of those things that, you don't want to be in the midst of fit testing as you've got a patient with measles in your clinic. I would also encourage you to do some assessment now of your risks. Are there workers in your environment who are not fully up to date on vaccinations, anybody who might be vulnerable. If somebody is, say, one of your workforce is unvaccinated and exposed, the recommendation is that they receive a dose of MMR immediately, and then exclude them from work for the next 5 to 21 days, because that incubation period can last up to 21 days. So that's going to be a significant hit to your workforce and your throughput. So that's why I encourage you to do that assessment now. Don't wait for measles to arrive. So based on my past history and my background in public health, you were not going to get out of here without some discussion of epidemiology, and also some of the resources that you might go to find current and local information. This is the New York Times, who is not normally somebody that I would recommend necessarily for public health information, not because they're bad at their job, but usually we go to the CDC. And the CDC does do a great job, but what they only really kind of report state level information, whereas I like this map because it kind of shows you where in Texas, because Texas is a huge state. Where is it in Texas, for example? And so the center of this outbreak right now really is in West Texas and eastern New Mexico, and it has traveled northward up into southwestern Kansas, over this way. And I know I'm in a flyover state, but I'm over here, so you don't have to worry about me just yet. But yeah, we're really monitoring this pretty closely in Kansas. We're the number 3 state right now, considering we're a very low population state. That's kind of scary. But we're the number 3 state for disease incidence right now for measles. This is an old slide. I gave a webinar to this organization in April, and I brought this because I wanted to show you what has changed in the last month. So during that time, we had 675 cases. We had 3 deaths as of that time. And this graph, or this table over here, comes from Johns Hopkins University. Where's my, oh, shoot, goodness. All right, we're back. So Johns Hopkins University during COVID emerged as a really good provider of dashboards for information with respect to outbreaks in public health. And so the image on the right comes from them, and a couple things are going to come from them in the next couple slides. So again, we went from 675 to now over 1,000. And this was as of the 8th of May. So CDC updates just about weekly. So we should expect a new update on Monday. And this is now in 31 jurisdictions. There are 14 active outbreaks in 2025. 93% of all of the cases are associated with an outbreak cluster. You'll notice that Georgia, I'm sure you already heard this, did have 3 cases in the Atlanta area. Those were associated with international travel, and they've been contained. So right now we do not have, to our awareness, active cases of measles in the state, which is very, very good. But you can see, again, if we flash back and forth, just how much this thing is moving. So wait, there we go. Okay, so here's some information from the CDC. This is what you can expect to find on their page when it updates next. On the right, for better or worse, and they don't care what I think, but I'm a visual person. I need things in graphs. And so the information you see on the left is the exact same information you see on the right. I just put it, and it looks like garbage. I don't know why that happened. I'm sorry. I will fix that and get it corrected for you. Man, that's a bummer. But you can see the numbers, which is kind of helpful. And so anyway, the majority, or actually, a lot of our cases are pediatric, right? They're either in that group under the age of 5 or they're school-aged kids. The hospitalization rate is much higher among the kiddos that are under 5 than they are the school-aged children. But unfortunately, the 3 deaths that we've had, 2 of them were in school-aged children, and 2 of them were in Texas. 1 was in New Mexico. So just so that you kind of know.
What was the cause of death of those 2?
It was pneumonia. Yeah. So again, pointing out something here where you see vaccination status, 96% of the cases so far have been among those who are unvaccinated or not fully up to date. So, okay, these are the news stories that I've been following, and these are the things that really kind of make your stomach come up into your throat as a public health professional. When you hear that index cases have been visiting very high density population centers where a lot of kids would be present. So things like a Great Wolf Lodge. I don't know if they have these here in Georgia, but it's basically an indoor water park. It's awesome. Another one, we're in Texas, where a daycare became an exposure setting, and you can imagine the impact on those kids, their parents who depend on daycare in order to work, and now their kids have to be in isolation for 21 days. So very significant impacts. And just recently, we had exposure at the Wichita airport, and so I just traveled through Atlanta Hartsfield, and there's a moment where you're sort of like, I'm vaccinated, I'm okay. But I'm looking at all these kids and I'm like, I wonder, what are we doing here? Not that they shouldn't travel, but I hope everybody is paying attention. So this comes from the state of Texas. Like I mentioned before, we can vaccinate infants who are between 6 and 11 months of age prior to international travel. And that has now become the recommendation for the state of Texas, but also Southwest Kansas has also implemented that for areas that have active outbreaks. So hopefully we never see this in Georgia again. But if we do, be prepared that this may be a thing. But also, if you have families that are planning to travel to West Texas, that are planning to travel to that Southeast New Mexico or Southwest Kansas, I think I said that already, you can consider doing this. I read a news report the other day about pediatricians in my area that were vaccinating their young kids before they go to Disney World because they knew that was going to be potentially a high-risk setting. So I brought this. This comes from that Johns Hopkins dashboard. Once again, what I like is that it shows us where are the active clusters, what was the site and the date of exposure, and how long do we need to be monitoring those folks. I'll spoiler alert, Georgia is not on this list right now, but we should all be thanking our lucky stars for that. But just in case you were ever wondering, like O'Hare International Airport is on there a couple times. So, Atlanta Hartsfield is one of the busiest airports in the world. We might expect this at some point. Okay, this graph will make you cry, or this slide might. So in 2013 to 2014, the map on the upper left is showing vaccination rate coverage for MMR. Blue is good. You want to be blue, okay? You don't want to be burnt orange. And so what we can see is present day situations, or more recent 23 to 24 on the lower right. And you can see we have far fewer states that are in that blue category. And this is why we think these outbreaks are occurring, is because we have dropped below sort of the herd immunity threshold that could be helpful in preventing the dissemination of disease. I told you the best data are local. Let's also take a look at Georgia. So same kind of color scheme. You want to be blue as much as possible. And what you can see is that we don't have very many of those in the state of Georgia right at this moment. Although this is recent as of 2023, this comes from the Georgia Department of Public Health and the Johns Hopkins resource page that I talked to you about. Next, I mentioned herd immunity. I really like this image over here because it kind of helps us to see and conceptualize how things might spread. When I push play on this thing in just a moment, you're going to see an index case in the middle and then disease spread through a red line. Each of these blocks has a different sort of percent vaccinated or percent immune. So we can see how the more people that are vaccinated, the better. Okay, I think we're ready. So you can see we don't want to be in that 0 or 25% range, obviously. That's where we were in the early days of COVID. We want to be in this 90% or 95% as much as possible. Because measles is so contagious, we actually need to be at or above 95%. 90% is not sufficient. And so the thought process behind this, as I talked about before, even with atypical cases, we don't see disease transmission among these folks. So the more you're vaccinated, the less you're able to transmit this to other people. And it reduces the likelihood that that vulnerable person is going to come into contact with somebody who's infected and then becomes sick. Whoops. Yeah, I already did that. Okay. So the problem is, measles is not the only thing we need to be worried about right now, because of the COVID pandemic, we saw a lot of children fall behind on their pediatric vaccine series. I'm sure you're well aware of this. And so what this has translated to for children that were born between in 2020 to 2021, we now have a situation where we are below the herd immunity threshold for just about everything except for polio and Hep B. And for measles, we're at 90%, which normally would be excellent, but because it's so contagious, we need to be above 95. So this is not a great place to be. So we're almost done, I promise. The key takeaways here I want you to remember is that measles has 4 disease stages, and they're infectious 4 days before and 4 days after that rash occurs. Most people are going to survive measles, but it's not without cost. There are some really common complications, and some of them can be very severe, especially for children under the age of 2. You're already doing it, but do talk to parents about vaccinations, especially prior to both international travel as well as domestic travel. And again, 96% of the cases that are occurring right now are among the unvaccinated, which kind of tells you about the success of the vaccine. So again, I just encourage you to really think about the when, not the if, of whether measles is coming to your city and coming to your clinic. Be prepared for that, because what we have found through COVID and other things is that fear is often what drives a lot of the sort of panic response and the misinformation and that sort of thing. So the more informed we can be, the more prepared we can be, the more confidence we can give to our parents, to our patients as we encounter these kinds of things. So I'll leave you with a quote that says the return on investment in global health is tremendous, and the biggest bang for the buck comes from vaccines. Vaccines are among the most successful and cost-effective health investments in history. So again, it's wild that we're here. I remember telling my husband that I was coming to do this, and he's like, "You don't research measles." And I was like, nobody does. Nobody does in the United States, because we don't need to. But what I am is a medical educator. And so I come here today to try to inform you so that you can inform those around you. With that, I'll conclude. Thank you very much again to the Georgia Rural Health Innovation Center for bringing me here today. And I look forward to your questions, if you have any.
Can you go back into slides where you have the indications for the vaccination for the vaccinated and on those?
Yeah. This one? Okay.
I have a question.
Ma'am.
Yeah, I've seen so many people kind of just focus on MMR, that they just feel this is the one that causes autism. What would you say to those? Because we have a lot of those in our clinic.
Yeah, I know. This is the one that kind of started that whole thing off, right? Unfortunately, I hear you. The thing is, everything that's ever been published about claiming a link to autism has been debunked. But once the sort of the cat's out of the bag, it's hard to put it back in there, right? And so I know that has made its rounds among some very, health conscious parents. But it really is not, unfortunately, based in science. And so I don't have the greatest answer. I think everybody is really trying to grapple with, how do I talk about this with patients, for sure. So my heart goes out to you. I think some of the more compelling things is that, it is a really safe and effective vaccine. And looking at some of these, data doesn't always convince people, because I think a lot of people make decisions based on their emotions rather than logic. I think it's always important, and I'm sure you're already doing this, to understand that the parent is trying to make their best choice for their kiddo, obviously, but you went to medical school. You have the knowledge that tells you that this does work and it is helpful, and it saves a lot of lives. One of the biggest things about public health is we are victims of our own success a lot of the time, in that the more lives we save, the less credit we get, because when a vaccine takes our infectious disease incidence down to virtually nothing, there are no parades. Nobody names hospital wings after us. That kind of thing. So my heart goes out to you, and I'm sorry we are here. Go ahead.
I have 2 questions for you, and it may not be right to direct this to an epidemiologist, but I don't know if every other pediatrician in this room is getting this question. I'm sure right now some parents are saying, I don't want to vaccinate because of the metals in the vaccines. They specifically will reference aluminum. And I know that give me a good response to that?
Yeah. So, and this ties back to your question too, with the autism or the thought that there's an autism link. There isn't. Let's be very clear on that. The thing that's interesting is that we removed a lot of those adjuvants and some of the metals from the vaccine, and yet our autism rate continues to grow because of better detection. And so I think that there's a disconnect, right, between if that were the case, we removed the offending ingredient, right? And so why would that still be a concern? So that is something that I have seen as a response to that kind of thing. What was your second question?
My second question would be your advice. Our office right now is discussing whether or not to be an office that will continue to have patients in our practice who choose not to vaccinate. And in the past, we've said, well, we're a rural clinic. These children need medical attention anyway. We are going to continue to have these conversations and still have them as our patients. But with this year, especially the increase in the reluctance, it's starting to make me a little bit nervous. Do you have any advice along those lines or thoughts?
Yeah, I think every clinic's having to grapple with that. And certainly it's a tough decision because, like you said, we have real significant healthcare deserts. And your clinic may be the only one that could see them, right? And so when that's the case, it's kind of like, well, I would rather see them than not, especially for other things that might be really important. But, I've seen clinics that have sort of a sick waiting room and a well child waiting room. And so that might be one way to manage things. There isn't a perfect solution for this. I'm really sorry that we're here. I wanted to come back to you because you asked for this graphic. What did you want to ask about it?
No, I didn't ask for that.
Oh, forgive me. I'm looking in the wrong spot.
No, I was unsure about the time between the doses.
Yeah.
Unvaccinated.
Right. So in that case, you are going to vaccinate them between 6 and 11 months, but then you're still going to follow the recommended series. So this child would receive 3 doses over the course of their childhood rather than 2. Thank you for giving me the chance to clarify on that.
Considering that you have that sort of immunity and amnesia after being ill, is there any kind of titer you recommend or revaccinating for other diseases?
Yeah. So you could run a titer on some of the more common vaccine preventable diseases to see, has there been an impact? And especially if we have simultaneous measles and pertussis outbreaks, it might be a good idea to run that titer to see where are we, and then perhaps give a DTaP or Tdap booster, depending on their age.
It doesn't seem to affect like the meningitis.
I mean, it hits everything. So there's the risk for sure.
This is not a perfect solution, and I'm not a doctor, so this is part of that. But telemedicine, some of you that are participants in the Kids ABC program, you can use those telemedicine for anybody, anywhere. So that could be, you have an unvaccinated family, and they are calling for an appointment because they're sick. Somebody you think, this could be something, you are more than welcome to use that telemedicine at your discretion, however, or whenever you want to use that. So if that's a helper in buffering some of that, you please. And if you don't have it, you're in a rural community, that's you.
Okay. Seems like y'all are experts now. You're ready, right? You're going to go home. You're going to tell everybody to get vaccinated. You know what the signs and symptoms are. You're going to check to make sure everybody in your clinic's vaccinated, ready to go. You're going to check your N95 supply. Is everybody fit tested? And now you know some resources. Go to that Johns Hopkins. It's called the Center for Outbreak Response Investigation. But if you just start typing up Johns Hopkins and measles, it'll come right up. I really like that resource. The CDC usually updates every 2 weeks on Mondays. So pay attention to that. That's when we should expect those to come up. Georgia Department of Health is a great resource, and I hope you'll lean on those officials as things progress. So good luck to all of you. Sorry we can't have nice things, but here we are. So thank you again for the invitation to speak.